2004, I joined the executive team of Spark as the director of research. It's actually quite interesting because although at the beginning of the planning, research was a key component of the laboratory, by 2004 it became clear that traditional research, experiments, would not be the main approach we will use to identify opportunities for innovation, but rather we would be using an iterative process based on design thinking to approach the challenge. And so as director of research, what I did was take advantage of a unique resource in healthcare that at the time we started recruiting, namely designers, to start informing my own research, not as part of Spark, but my own personal research program in terms of can we use design to modify some of the interventions that I'm planning to experiment with as part of my own research program. My own research program at the time was focused on helping patients make better decisions. And as I start to understand design thinking, I started with the help of other professionals in design, trying to think about how can we use design to change the way we help patients make those decisions. Say you are a patient with diabetes that has been struggling with a condition for a few years. Your doctor has prescribed a few medications that you're trying to take, has insisted on you exercising and being careful about your diet, has required you to check your sugars and present the results of the check in the next visit. And you're coming into the visit, and you know there's going to be a test of your average blood sugar in the last 3 months. And when you come into the visit, the doctor doesn't ask you how your efforts have been going, does not acknowledge the fact that you may have been partially successful in a few of these, but holds you only accountable to the result of that blood test, and then tells you your test shows that your sugar control has not been good. In fact, it's potentially a little worse than the one 3 months ago, and immediately you feel labeled as a bad patient, and you feel that you just showed up at the principal's office and you're being scolded. The likelihood that you'll benefit from that interaction, the likelihood that you'll come back to the next appointment, I suspect go down dramatically by the fact that you have not, some of the things you may have done right have not been acknowledged, and you're being held accountable to a single parameter of success when you are a complex, multi-dimensional person. What if during these last 3 months you were struggling with a sick kid at home, or maybe a trouble in your marriage, or difficulties at work that limited your ability to take care of yourself? You're probably looking for compassion, advice, tailoring of the program to your new circumstance. The last thing you're probably looking towards or forward to is being scolded. And again, those interactions, which I think many would relate to, are designed either explicitly or implicitly to deliver the experience that they deliver. What if we were to rethink that visit, think about what are the objectives that we pursue, and for instance, consider the patient a partner, consider the patient as a complex individual living in a complex setting, and we try to provide support and expert advice along the way. The result will be likely to be different. So the question is, are these interactions subject to innovation? Are these interactions subject to change towards improving their value? And if the answer is no, then there is no opportunity for innovation in healthcare. And if the answer is yes, the question is, how do you do this? And that's the adventure in which we embarked ourselves back in 2004. One was designed to help patients with diabetes make decisions about cholesterol medications. At the time we designed those, the guidelines for care required all patients with diabetes to take a cholesterol medication. Statins are called. And when you tell everyone to do, when you tell clinicians every one of your patients should be on this, they would try to make that happen. And the way they would try to make it happen, as we found out in our initial observations, where they would say, oh, by the way, because your cholesterol is high or you have diabetes, you must take this medication, and here's the prescription. And that was the nature of the conversation, the totality of it. Some patients may ask about adverse effects, but there were few. Most of them said thank you and took him home. Study after study showed that patients were not able to take the medication over time, either because they didn't understand why, or they didn't agree why they would use them, or they would forget to take them, or who knows, it became too expensive. But the issue was that at the end of 2 years' time, half of the patients to whom these medications were prescribed were no longer taking them. And the studies had shown that you need to take them for at least 2 years for these medications to make a difference. So we thought that we could, instead of just saying to patients, go ahead and take it, we thought, well, what if we explain to patients and show them in a graphical way what the risk of a heart attack in the next 10 years is for them. So we show them out of 100 people like you, and we use little happy face pictograms. Out of 100 people like you, for instance, if your risk was 20% in 10 years, 80 will not have a heart attack and 20 will. And then we will acknowledge to them that we have no way of knowing if they were among the 80 that would not have the heart attack or among the 20 that would have one. And then because of that, because we didn't know who this particular patient was, we'll have to assume that they could be part of either group. So if we were to give cholesterol medication to any of these people, or to all of them, what would happen over a period of 10 years? Well, the 80 people that were not destined to have a heart attack cannot benefit from the medication if the intent of the medication is to reduce the risk of a heart attack. So they will just take medication every day for 10 years with no expectation of benefit. And the other 15 will have the heart attack despite taking the medication regularly, and only 5 would avoid the heart attack by taking the medication regularly. Again, we acknowledge to the patient that we had no way of knowing if they were among the people that were not destined to have a heart attack, the people that were destined to have a heart attack will experience no benefit, or the people that were destined to have a heart attack that avoided by taking the medication. So now you have 2 instances where clinicians acknowledge uncertainty, which is unusual in the conversation. You quantify the risk and you quantify the benefit. And then we also did the same thing for the possible adverse effects. And what we found was that, and we randomly assigned the patients to receive this intervention or not. And what we found was actually quite interesting. The intervention group that got the decision aid got much higher scores in terms of the satisfaction with the visit, in terms of the knowledge that the patients accrued from the interaction. And we were able to demonstrate an improvement in the adherence to statins, to the cholesterol medication, the extent to which patients were able to use it regularly over the first 3 months. Interestingly as well, we saw that low-risk patients were less likely to get a prescription than high-risk patients in the group that got the decision aid, where the risk of the patient was not a predictor of who got a prescription in the control arm, in the usual care arm. So in our usual care, we had been risk blind. We were doing the same intensity of care to people at low and high risk. In the intervention situation, we became more risk aware. So overall, an improvement over what arguably was very good care by a simple tool that was designed to meet the needs of patients and clinicians. And this was our first success. Also the first time that we got direct evidence of the generosity of our clinicians and colleagues who were flexible enough to move a whole clinic to answer a question about ways of improving their care.